Hi, Dipti, and thank you for inviting me, and thank you. I thank the organizing committee from AIOC for having me today. So, can you see my slides, Deepthi?
Perfect. Perfect.
Wonderful. So, we did discuss about this epithelial ingrowth and management in the first few cases. So, I'll be taking through one of a case where I've managed slightly differently. So, a 35-year-old female who presented to us with a history of LASIK 4 years ago. And then she did give us a history that her right eye had an issue wherein the flap, wherein glue was used for getting the flap in place 2 months after the primary LASIK procedure. So, and then she noticed an increase in the opacity and worsening of the vision in the right eye at least 2 years after the procedure. And on examination, her visual acuity in the right eye was 20/30, and the left eye was 20/40 and was improving to 20/30. But still, she was more worried about the right eye because of the opacity and the gradual worsening of the vision. So this was the right eye slit lamp photograph that you see here, a white opacity over the cornea. So when we look at it, it was at the interface, and it has been gradually increasing as per the patient. So it is a no-brainer. Like anybody who does LASIK would straight away jump on to say it's an epithelial ingrowth. So when we look at the causes of epithelial ingrowth, these are either because of proliferation of implanted cells during the procedure, or these could be because of constant migration or proliferation of epithelial cells, where there's a source supplying these cells with help of a track to the interface. So either of these mechanisms, the epithelial ingrowth can occur. So whenever you see a patient with epithelial ingrowth, it's very important for us to assess the reasons. So especially in situations like buttonhole or the flap related complications, there can be a continuous supply of epithelial cells that can lead to accumulation in the interface. So I think looking at the flap edges is very crucial when you come across a patient with epithelial ingrowth. So this is how we saw the patient, and it's when you have seen an epithelial ingrowth in a patient who underwent LASIK by someone else, and you have not prepared a flap. I think it's very important for you to look at the flap configuration. So here, if you look at the flap itself, so in the periphery, you see a lot of scarring that is noted. So since a second intervention of flap lift was done, we do not know what exactly happened, but it is important because if you intend to lift the flap, you need to understand your flap better. Otherwise, do not lift a flap. So let's look at what is happening at the periphery. So this is at the inferior temporal aspect of the right eye, where you can see significant amount of scarring. There are a lot of tracks that are seen leading to the center, and there's significant amount of scar where you will not notice a delineated edge of the flap. And let's look at the other areas. So this is at the superior nasal aspect. So here you can see peripherally scarring, prominent scarring. This could be aborted epithelial ingrowth where they didn't proliferate and then stop. But otherwise you could see there's some stray and then scarring or a track from the flap edge towards the area of epithelial ingrowth. But you do not see along the track any epithelial cells. And if you look at the inferior aspect of it, like you can see, let me go back and show you the previous one. So if you look here, there's a track and inferiorly as well, which could be a potential source of epithelial cells, but now it looks clear and scarred, and there are no epithelial cells in the tract. So you have a flap which is irregular all across, and you have a glaring epithelial ingrowth in the center. How do we manage this? So before that, we went ahead and did an OCT. You can see a globular, elevated, very thick epithelial cells in the interface, which is causing indentation in the posterior stroma and the flap as well. And the adjacent scarring also can be seen, wherein lifting a flap in such a situation would be very difficult. And we looked at the topography. You can see a lot of irregularities in the axial and the tangential map as well. So what do you do here? We've discussed about this, like flap, lift the flap and scrape. So you know that there's significant amount of recurrences. Next is lift the flap and then put sutures and glue once you remove. So we do not know the configuration of the flap. We did notice a lot of scarring in the periphery. Lifting in such a flap is very difficult to keep it back. And also with these maneuvers, the recurrence of epithelial ingrowth is very high. What about using adjuvant therapies like ethanol or absolute alcohol? Here also you will see a lot of complications like recurrences, DLK, and flap melt. PTK is one of the methods which can be used for recalcitrant cases. Here we do have a very irregular flap and there's thick epithelial ingrowth. In these cases, doing a PTK may not be very wise. So we went ahead and looked at what else can we do, and we found that Nd:YAG laser is a non-invasive procedure which can be done in patients where a previous free flap or a flap lift was done, or if you have a scarring of the flap edge, or if you're unsure of the configuration. I think if you have a localized epithelial ingrowth, Nd:YAG laser would work for these patients. So we went ahead and did Nd:YAG laser for this patient. We used a very minimal amount of energy. We start at 0.3 or 0.4 millijoules to see the bubbles in the interface. So we start at the periphery, we start at the center and go to the periphery. So this pattern can be varied based on the type of epithelial ingrowth. So we used few shots, 8 to 10 shots in the epithelial area of maximum epithelial ingrowth. And we observed the patient in 2 weeks. The visual acuity improved with pinhole to 20/25. But if you see closely, you can start seeing the translucent area, that is less opaque area in the periphery, and it started shrinking in size. So that gave us more confidence, and we went ahead and did a second sitting of this thing, and that's in day 14. You can see the epithelial, you can see the bubbles here when we do after the YAG laser. You can see the bubbles in the interface. And this is how it would look on a closer look. So you can have few bubbles seen in the interface in the area of epithelial ingrowth. That would be the end point. And day 30, we did see significant decrease in the epithelial ingrowth, and the density of the epithelial ingrowth has come down. And then you can see the visual acuity has improved to 20/25. That's a line improvement. And this is a closer look at this. And then if you here closely look at this, it has shrunk further, and it has become from opaque to translucent. And this is a day 60. And then we did three sittings by then, and day 60 we see a significantly decrease except for a few areas of white spots that you see here. And then if you closely look at the epithelial ingrowth, and shrinking its size and decrease in density as well. And the OCT also shows scarring in the interface, but we do not see very significant thickening that was seen before. And at 2 years, you can see a significant decrease in the epithelial ingrowth. You can see very stable, except for a few areas of those deposits. Otherwise, patient has been stable over 2 years period after 3 sittings of Nd:YAG laser. So has it benefited the patient? I think yes, though there's just one line improvement in vision, but patient's happiness with the fact that her quality of vision has improved significantly was a big benefit that we gave to the patient. This is pre-operative on your left and 2 years post-operatively on your right. And if you look at the topography, there's a stark difference that we see in the right eye pre-operatively, as you see on your left. In the center, you see at 2 years, and the difference map on the right eye. A lot of parameters have been changed with epithelial ingrowth resolution over a period of time. So I think Nd:YAG laser is a less invasive and effective technique for the management of epithelial ingrowth after LASIK in certain situations.